Okay, we are talking about the accessory ossicles, which are the epiphyseal or the apophyseal ossification centers that do not actually fuse with the main bone. All right. Okay. So here, what actually, when we are trying to look at the accessory ossicles in the pictures, what I have transferred you, you can actually understand that the apophysis, the fifth metatarsal apophysis, is the one that actually gets ossified at the age of 40, right? After the 40, it is completely fused. So when it is not, generally, fusion generally happens in the adults. Okay. Sometimes, even if it is not fused, yes, it should be a completely normal way itself. Okay. So you need not really confuse yourself that if it is not getting fused. Okay. So generally, this fifth metatarsal apophyseal fracture generally happens in people with kickboxing. Okay, in people with kickboxing, actually, that is where the point of impact will be. So, in those people, generally, it might actually get, fracture. So, not necessarily every time, but yes, most of the people will actually have this ossification by the age. Okay, age of 40 years, yes, it will completely get ossified, but still, generally it is getting ossified at the age of 10 years for girls and 12 years for boys, right? Generally, fusion will happen down in an adult, or a complete ossification will be completed down by the age of 40 years also. So sometimes it can be actually called as a normal variant itself. Okay, so you should not misunderstand the apophyseal ossification centers as the fracture lines. Okay, so you should be aware of at least this point here. Okay, then you have to understand one thing here, that the old or unhealed fracture fragments can sometimes actually mimic as acute fractures. You see here, when the classification I was telling you, that there is an acute fracture which is less than 5 days, and a chronic fracture which is greater than 5 days, or the healing that has started down or commenced by the 17th day and has already completed by the 21st day, and up to 30 days, it may extend up to 21 days to 30 days. Okay, a complete healing of a fracture can happen depending upon the part of the body. It actually takes up to 60 days. All right. So, but however, if it is less than 5 days, you can actually see that the healing hasn't commenced yet. So that is a true fracture. But sometimes in old fractures, okay, if it has extended beyond the limited times of the healing, what actually happens is that you can see that the unhealed fracture fragments can also mimic them as acute fractures. All right. What actually happens is that these small bones, okay, are corticated in the sense that their healing has completed. Osteoblast has actually taken down the healing process, and that there is a white line that is completely surrounding the bony fragments, and their edges are usually smooth, which means to say cortication is a process of fracture healing. All right, and their edges actually become smooth. This one actually suggests that it has been healed. But in unhealed fractures, what actually becomes is that they also might mimic like, or they can look like acute fractures. And then in case of sesamoids or the ossification centers, they usually are bilaterally symmetrical. You see here, so that's the reason whenever you are suspecting if there is a fracture in the apophysis region and you are actually unable to classify it, so that is the time when you are actually going to prescribe the other side of the body x-ray as well. And then you are going to compare the symmetry of those two things, and then you have to make sure if it is a fracture or if it is a apophyseal ossification center or not. Okay, and then generally they are occurring at the anatomically predictable sites. Another best example where the ossification centers do not happen is the distal end of the humerus or the proximal end of the humerus. Okay, or sometimes you can actually say that it is the lateral medial edge of the tibia as well. Okay, or the distal edge of the uh, tibia and fibula as well. Okay, all of them are the anatomically predictable sites. All right, they happen generally. These ossification centers are present. Apophyses are generally present in long bones. All right. So when you are trying to look at the apophyseal center, you have to compare it with the symmetry. and then if it looks both of the places actually look the same in both the x-rays, then you can actually confirm that one is an ossification center, and generally they can be misdiagnosed as fractures. So just remember the anatomically predictable sites where the ossification centers or the sesamoid bones appear. All right, then there are almost sesamoid bones present in the thumb. Yes, thumb is also one of the best example. And the posterior lateral aspect of the knee, right, the fibula, that is what I am talking about before. And then also the great toe, the accessory ossicles that are present down in the most commonly present down in the foot. So the great toe is the first phalanx, right? And then the fifth metatarsal, yes, it is also an anatomically predictable site. Humerus heads, okay, distal and proximal heads, or the tibia and the fibulas are also one of the best examples. So I will make a list of all these things and I will put down in the practical slides. But first you try to understand that these are the ones that actually tend to cause a misdiagnosis of a fracture. Right, now you see here we are looking at an old unhealed fracture fragment. You see here this, what bone am I pointing to here? What bone am I pointing to? Alna, okay, is it a right hand or a left hand? Okay, you see here, is one an adult or a child? It's right hand. Okay, can you guess the age of this person? It's an adult because I can see all the carpal, right? I can see all the carpals, right? So you see here, this one is actually the pisiform bone, and right now at the pisiform bone, you are actually looking at the styloid process of the ulna, right? Styloid process, and then you see here that one actually, this one is not an apophysis since this is an adult, and it means to say the the distal end of the radius and the ulna should have been completely ossified, okay? And right now, but still, you see here, at least when there was some kind of a fracture in the history, right now this one is appearing down as a different fracture fragment. So this one is an old and unhealed fracture where the ossification should have completed along the styloid process, and that one did not complete. So that's the reason this one is an unhealed fracture, but do not misdiagnose this as the apophyseal ossification center. All right, is this point clear here? Yes. Okay, now you look at here on the other side. Okay, can somebody tell me what I'm looking at here? What is this x-ray that I'm looking at here? No, I'm talking about the number B. Yeah, it's the A is the wrist joint, obviously. Okay, what phalanx? Which phalanx? Which phalanx am I looking at? Okay, is it a hand or is it a leg? Okay. You see here, there are some hyperdensities that are present down here. Okay, these hyperdensities are generally nothing but your sesamoid bones. All right, so these one are actually passing down within the tendon. So that's the reason you call them as the sesamoid bones. All right, so and that is how you have. Then you see here, this is actually what we are trying to find out is the one, this one I'm talking about the fibula or the tibia and the fibula things. Okay, uh, you see here, this one is actually called as the os trigonum. Okay, os trigonum accessory ossicles that are actually not fusing up with the parent bone. All right, so this one is not fusing with this one, so you can actually call, and this one a look like a fracture, but you have to understand that the accessory ossicle edges are completely smooth. Okay, a fracture edge is not smooth, whereas the accessory ossicles edges are smooth. Okay, so that's one or the three pitfalls that you should be learning about. Okay, you should be learning about the unhealed fracture fragments and where you are looking for the cortications, and then you are actually looking at the sigmoids, which you are comparing it with the symmetry, and then there will be, you know, the sigmoid bones that are actually present down within the uh, what do you say, within the tendon. All right, so that is how we are actually looking at for the things that actually mimic like fractures. And now here, all of them are generally, you see here, there's a differentiation. What actually happens is that the abrupt disruption of the cortex is actually present down in an acute fracture, or the sigmoid or the accessory ossicles, yes, they do not have the disruption of the cortex. Then yes, bilaterally symmetrical. Okay, and then generally in a fracture they are never symmetrical. Okay, fracture line, unless it is a road traffic accident, okay, even if there is a road traffic accident, but still there won't be symmetrical lines, because the impact or the action dynamics that is taking place on different bones is entirely different on both the sides. Okay, it is actually depend upon the point of impact, okay, or the point of impact or the force of impact that is happening on that particular bone itself. So that's the reason an acute fracture, they are never symmetrical, and whereas the accessory ossicles and sigmoid bones are generally symmetrical. Then the fracture line is generally not sharp, it is jagged, and the edges of the uh, the fracture are generally very pointed. Well, whereas the smooth sigmoid bones, they are having a smooth edge, and then the bony fragments has a completely cortex around it. Generally, no, this is the uh, disruption of the cortex as they present down in a fracture, where the sigmoid and the accessory ossicles do not have the disruption of the cortex, so they are smooth and there is the presence of a cortex all around it. Okay, so that is how you are actually going to differentiate the fractures from the ossicles and the sigmoid. Okay, this is an important question, so remember it. Pitfalls related down to the fractures. All right, now, well, we are trying to learn about the dislocations and the subluxation. Okay, you remember there are two types of abnormalities in the joints. Okay, when it is coming down to the trauma, you actually call it as the dislocation or the subluxation. So in dislocation, what actually happens is that the bones are originally forms of two components of a joint and are no longer in opposition to each other. Generally, the dislocations occurs only at joints. You see here, when the articular surfaces, okay, articular surfaces is in the sense where the one edge of the bone is actually meeting with the other edge of the bone to form a joint. Now, this kind of anatomical relationship is actually gone. Okay, if it is not seen along the joint, okay, it is actually called as a dislocation. So certainly yesterday we were talking about uh, let me show you something, and you can actually understand that one, so that try to we can see what exactly am I talking about. Okay, look at the image I have sent you. Okay, and try to see and understand the dislocation well. Okay, just a second. Okay, have you seen the image I have sent you? See, In this image, actually, you can understand that both the articular surfaces of the shoulder joint, okay, the glenohumeral joint, where the humeral head is entirely separated from the glenoid capsule. So such one is actually called as the loss of relationship between the articular surface. So you can classify it as a dislocation. All right. Now, whereas the subluxation, okay, subluxation is an entirely different situation where the bones that are originally formed actually gets down to the two components of a joint are in partial contact with each other. So subluxation of a joint generally is happening. Subluxation, actually happens only at joints as well. Okay, but here the bones that originally form the two components of a joint are in partial contact where there is a complete, okay, where there is a complete loss of anatomical relationship is actually called as a dislocation. Where this subluxation, yes, at least some part of the joint, the bones that are actually forming the two components, they are in partial contact with each other. So right now, let's try to understand what exactly is a subluxation. You look here, what is the X-ray that I'm looking here? What is the X-ray that I'm looking here? Yes, it's a foot. Okay. Where do you actually see if there is a dislocation or not? Okay. Where do you think that the problem has been present? Okay. Well, stop using it as the little finger things. Okay. Either you tell it as the fifth phalanx, first phalanx, or something like that. All right. Don't use colloquial terms no more. You have to get used to say that one. Okay. See, it's not the distal part of the fifth phalanx. Okay. It is the distal phalanx. All right. There is nothing that is called as the distal part of the phalanx. Okay. It's the distal phalanx. All right. Fifth distal phalanx. All right. And you can see here that the fifth distal phalanx actually has got a complete, okay, a complete loss of anatomical relationship with the proximal joint, right? You see here, and you can see that this complete articular surface is completely has lost its relationship with this, uh, you know, this what do you say, interphalangeal joint, right? So that is, you can actually say that there is a dislocation of the fifth phalanx. Whereas a subluxation, okay, in subluxation generally you see here there is a partial partial relationship of the humeral head with the glenoid capsule. But the other image I actually showed you that it is not in the relationship, but still you see here when you are trying to look at the acromion and the coracoid process relationship, yes, there is still seems to be occurring some kind of a relationship. You see here, which means to say if it is relocated down into the position, yes, it gets back to normal. All right. So that one is actually called as a subluxation. All right. So they are in partial head of partial contact here. You can actually see that the humeral head is generally almost present down inside the humeral head and the distal edge of the humor, or you can actually say that the inferior angle or the inferior surface of the glenoid capsule, right? So this one is actually called as a subluxation. But you can see here there is also a fracture. Can you actually recognize the fracture that is present down in this picture? Okay, where can you say that there the fracture has been present in this picture? See, there is nothing that is actually called as the neck of the humerus. There is a neck which is different from the surgical neck. Okay, Shubham. Neck of the humerus is entirely at a different location. Surgical neck is entirely at a different location. All right. So you can actually appreciate it here, even though there is no such kind of a radiolucent line, but you can actually see that the surgical neck of the humerus, okay, surgical neck of the humerus actually has invaginated down into the humeral head, and that one is actually showing up as the complete discontinuity of the cortex on the both edges. So this is a complete fracture of the surgical neck of the humerus. Okay, right? This is not the neck of the humerus, because the neck of the humerus is present around this place. Okay, surgical neck is present down along this place, right? So neck is entirely different from the surgical neck. Okay, right? So you can actually see this is a subluxation where the components of the two components of the joint are actually in partial contact, and there is also a presence of a surgical neck fracture. So how can actually this kind of an injury can be happening? Just think for a while and say it. What could have happened in this person? Well, first tell me one thing. Are you looking at an adult or are you looking at a child? Is this a child? Is this a child? Are you sure? It's an adult. Why? Because there are no epiphyseal lines, okay, that are present down along the edges. Okay, no epiphyseal line, completely fused. Okay, what is epiphany, man? No. Okay, right? And then you tell me what kind of injury could have happened to this person. Can you guess the injury, mechanism of injury? Well, it could have been a road traffic accident, that is for sure, or it can happen also with some other kinds of conditions. No, it's not about the stretch. Stretch should actually cause dislocation, but it will not actually cause the fractured neck. All right. Yes, it could have been a road traffic accident, or it could have been a fight where the persons have been hit on the shoulder, okay, with a rod. Okay, the person has been hit on the shoulder with a rod, which has actually caused that impact could have actually caused the dislocation of the joint, and also could have broken down the surgical neck. Well, no, boxing generally they do not cause this one. Back generally in boxing things, unless if it is a direct no, Shafiq, it is not the fall on outstretched arm. Fall on outstretched arm can generally happen down along the radius and ulna. It does not happen in the humerus. All right. Yes, weightlifting could also can be one of the problems, but generally weightlifting will actually cause the clavicular fractures as well, because when you are trying to lift the weight, finally the weight is falling down onto your chest, and it is disrupting the clavicle. So this could most probably an RTA, and yes, or the person could have been hit with an iron rod, something where over from above the shoulder, and the impact was on the surgical neck region. All right. So beating with a blunt object from the sidewards, or meeting down with a road traffic accident where he has been hit along the bumper, along the shoulder by a bumper or something. Okay, bumper injuries could have happened. Okay, road traffic accident and a fight could be the best explanation for this person. All right, right. So now how actually you are going to try what is the some of the dislocations and the subluxations. Okay, you have to remember the names here. Okay, you see here in the shoulder there are three types of dislocations. There is the anterior dislocation and subcoracoid dislocations. Okay, this is the most common, where inside of a hip it will be the posterior and superior types of dislocations are much more common, and it is actually caused by a combination of abduction, external rotation and extension. Remember the mechanism of injury here. You see here, it is caused by a combination of abduction. Okay, abduction means to say that you are moving away from the body, you are moving the hand and moving the shoulder joint away from the joint, away from the body. Okay, so you means to say you're rising arms by the sides. And then there is external rotation. External rotation in the sense when you are actually moving the hand to the back. Okay, when you are moving that hand to the back, which is actually called as the external rotation. And then there is an extension. Okay, that generally it should cause hyperextension here. Still, it is caused by a combination of abduction, moving away from the body, external rotation, moving it backwards, and there is an extension. It should be present down in an extension. All right. So all these things is actually causing the shoulder subluxations or dislocations, you can call it. Right. Frequently, where in the hip joint, it can be actually caused by a knee, where it should be happening because of a striking the dashboard of a car. Okay, dashboard in the sense that is the board that is present down in front of the steering wheel, right? So dashboard injuries actually cause this one, and then which actually transmits the force to the hip. All right, so this one is the most common type of injury that is happening around the hip. Did you understand? Let us imagine a person that has been sitting in the passenger seat of a car, and then there has been a head-on end collision, okay, with a on the ongoing vehicle. Then what actually happens is that the dashboard is actually going to, you are sitting down where your knees are flexed, right? Knee is flexed, and yes, your hip is in also a partial flexion, right? So now when the dashboard is actually hitting this one, actually the force from the knee is actually transmitted down to the hip. Did you understand this one? Yes. Okay, the mechanism of injury in hip. Okay, while you are sitting in a car in a passenger seat, your knee is in flexion. Okay, your knee is in flexion, and your hip joint is also under partial flexion. Right, now what actually happens when there is a head-on end collision? What happens is that the force, the point of impact, is actually going to transmit the force from the knee to the distal end of the femur to the proximal end of the femur, which actually dislocates your hip joint or subluxates your hip joint, right? So now, what are the fractures that are actually also associated with the humeral head? The fractures that are also happening along with these subluxations also can be called as a deformity. And the best example here is the Hill-Sachs deformity. Okay, what you looked at the X-ray before is the Hill-Sachs deformity, and the glenoid also actually has a fracture where the glenoid capsule is also being ruptured, which is actually called as Bankart fracture. You see here in this image, you see here there is a fracture along the glenoid capsule as well. You see, right? See, humeral head has been fractured as well, and the neck has been fractured, surgical neck has been fractured, right? And along the glenoid capsule, yes, there are minute fractures that are seen here. So such kind of things, actually glenoid capsule is present down along the inferior edge. Since the point of impact and the fractures that are present down here at the inferior edge, so you have to suspect the cartilaginous fracture also along the inferior surface of the glenoid capsule. So if that is actually going to happen, it is actually called as Bankart fracture, where there is other fractures that are also associated with the head of the humerus. What we are actually calling it as the Hill-Sachs deformity. So the X-ray what you are looking at is the Hill-Sachs deformity. All right. Now, where it comes down to the hip, it is actually causing associated with the fractures where the posterior rim of the acetabulum is being affected. You see here, acetabulum is a very, very true joint, okay, where there is a complete ball and socket joint, where humerus is also a ball and socket joint, but still it is in partial contact, right? Like I said yesterday, that the inferior surface and the anterior surface of the glenohumeral capsule is not covered, right? But in when compared to the hip joint is a complete round structure, and the acetabulum is completely covering the hip, the head of the femur, right? the head of the femur is securely present down in the acetabulum, where actually when there is an impact that is present down on the proximal end of the femur, is transferring the force down to the head of the femur. And now where is the direction of the force? The direction of the force is posterior. So in such kind of situation, what you actually see that there is the posterior rim of the acetabulum that is affected here. Okay, is this point clear? Were you able to understand the dynamics here? Yes or no? Yes. See, you actually need to know such kind of a details, because most of the times road traffic accidents are or any kind of a fracture actually indicates that there has been some abuse. All right, so that's the reason you need to concentrate on this kind of action dynamics, or you are trying to understand the mechanism of injury, so that actually the person that is responsible for this kind of injury should be prosecuted. So this is actually an MLC case. Okay, you call it as MLC, which is called as medico legal case. Okay, so any kind of a doctor, as general physicians, when you are graduated, you will be working down in a community health center. When you are trying to work down in a community health center, the police will be frequently coming down to you with such kind of cases on the road traffic accidents or the home abuse cases, fightings, gang wars, or something like that. All right. So you, the doctor, need to actually certify it if you are suspecting if there has been abuse or if there has been a complete accident, and then you are trying to classify it, and you are helping the police to find out what exactly happened according to the situation. You understand why actually trying to learn these action dynamics is very important? You understand? See, I suggest you guys actually go down and read your forensic textbooks to actually learn these medical legality issues. All right, make sure that you are actually keeping all these things in mind when you are analyzing a fracture. All right, a point of impact. What is point of impact? What is the transmission of the force? What is the direction of the force? How much force has been used? And what are the liable fractures that could be present? Okay, so every fracture may not be apparent. Okay, it may not be visible all the time, but still, while you understand the action dynamics, what actually helps you, it will actually help you to suspect where the fracture could have been present. Did you understand? Let us say if you took a hip joint x-ray on a person, and generally you never asked what happened and you never investigated about the action dynamics here, what you are doing is that you are liable to miss the fracture that is actually present down on the posterior rim of the acetabulum. Yes, it could happen with a problem where, for something like for Dr. Benedict, who was unable to understand the difference between the cartilaginous injury or the destruction when it is compared down to a fracture. You see here, acetabulum is covered down with the cartilage. Glenoid capsule is covered down with the cartilage. When you do not understand, you are not suspecting that there should be an injury of the cartilage, and you are ignoring the necessity of writing down a CT scan related to that patient. And you just saw the x-ray and there is no fracture, but doesn't necessarily explain the swellings, doesn't necessarily explain all the symptoms that the patient have been presenting. So you will be pushing the patient more towards a clinical condition called as avascular necrosis. Yes. See, humeral head has got a tendon that is actually connected down to the acetabulum, which also got the blood supply, right? And that blood vessel is being disrupted here, and that one is going to cause the complete femoral head loss of blood supply. Now that is happening. If you did not treat this patient, if you did not understand this patient, you are pushing down the patient to a condition called as a vascular necrosis. And finally, what actually happens is that you are liable to cause the complete hip replacement later on in the time in this patient. It not only happens, avascular necrosis not only happens in road traffic accidents, but the main important reason related down to avascular necrosis is acute pancreatitis. Remember, avascular necrosis could happen in patients with alcoholism. Acute pancreatitis is the one that is actually causing avascular necrosis. Road traffic accidents generally happens in alcoholics. Well, some unfaithful people are also present. Yes, road traffic accidents, trauma is also one of the reasons for avascular necrosis. Well, can somebody tell me what is the relation between avascular necrosis, avascularity, when it is related down to the pancreatitis, and why it is happening only down in the head of the femur? If you are curious, I think I will. You should find out the reason and know why. Okay, maybe do one thing. You guys get back later, and then you try to find out what is the relation between the acute pancreatitis and avascular necrosis of the femoral head. All right. Okay, that's one of the homework for you. Let's try to find out the pathophysiological mechanism there. All right. Now, how are we going to describe a fracture? Whenever there is a fracture, how are you going to analyze, and what are the things that you are going to concentrate? Yes, a fracture classification has got a fracture description has got four major components. Okay, four major parameters are there. First, you need to see if the fracture is complete or incomplete. Then you are going to define it as the acute fracture or a chronic fracture. After you do that, you are going to look for the number of fragments. Remember, if there is a fracture where there is a large force that is included, then a large force that has been involved, then what actually happens is that you are likely to see that there will be so many fracture fragments, which means to say the part of a bone has been broken down into number of smaller bones, which are actually called as the fracture fragments. So always the analysis when you are looking down at an X-ray or a CT scan, your main aim is to find out the fracture fragments, the number of fracture fragments, because even a small fracture fragment that has been left out during the surgical treatment will eventually cause a necrosis and infection in that patient. Understand? Because even a bone is a solid structure, but it is an organic structure which actually requires blood supply. Are you getting my point? Yes, a blood supply is necessary because it has got the spongy bone and it has got the medullary cavity, right? All of them which has also got bone marrow, which means to say there is blood supply, and it is securely protected outside from the external environment. So what actually happens is that when this anatomical relationship is actually lost, what actually happens is that there will cause an infection, which will eventually lead down to a clinical condition called as osteomyelitis, right? Okay, unhealed fracture fragments will cause bone infections. Okay, so later on, so that's the reason you have to always count for the number of fracture fragments, right? Next, you have to understand the direction of the fracture line. Okay, direction of the fracture line. Direction of the fracture line, is it happening from the medial side to the lateral side? If it is present transversely as a straight line, if it is present obliquely, or is it present down along the all extension of the bone, all the circumference of the bone, you can say. So that is the direction of the fracture line. We will see the pictures, you can get more understanding about this. Then the relationship of the fragments to each other. Okay, the relationship of the fragments to each other actually says that it needs what kind of intervention. All right, so the relationship of the fracture also should be seen, especially when it is related down to the fractures along the joints, right? Then you have to actually also see if the fracture actually communicates with the external atmosphere. Let us say the external environment. Sometimes, let us try to understand one thing. You see, when I was actually, working in India, I actually had a patient. Well, he was traveling down on an automobile. All right, he was traveling on an automobile at a, at a speed of something around like 80 kilometers per hour. Then suddenly there was some kind of, he was actually traveling on a very big motorbike. All right, and there was some kind of a, car that has been coming down from the opposite side and hit him, right? Then what actually happened is the both of them are actually moving very slow. Okay, sorry, not 80 kilometers. Actually, he was moving something around like 40 kilometers, which is the economy speed, right? Now, when actually he hit the car in front of him, what happened is that the whole bike fell on his left femur. All right, okay, the whole bike, okay, which is a very very big thing. It is weight, a lot of weight is present down, and it directly fell down onto his hip, and the femur actually got fractured. Right now, what can you suspect here? Okay, can it be a piercing injury is going to happen, and the bone of the femur, okay, the bone is actually going to become very pointed, and it is actually going to pierce through the muscles and the subcutaneous tissue and finally coming out. So such kind of a fracture is actually called as external fracture. Okay, there are two types of fractures: internal fractures and external fractures, or you can call them as closed fractures or open fractures. Closed injuries and in open injuries, I think you know about this one in forensics, right? Right, the same way the fractures are also classified. Right now, what actually happened when that particular individual whom I saw is that, the femur is completely, the diaphysis of the femur is completely piercing the subcutaneous tissues and actually coming out. So it became an open wound. There is a massive hemorrhage in that patient. Right now, it is actually very very important, because if there is any outside communication, it actually tells us that you need to secure all the organs that have been involved in between. Not only fracture correction has to be done, but also, the correction of all the subcutaneous tissues, all the fascia, all the muscles that have been injured, all need to be, repaired. So you have to differentiate the number of fragments, the direction of the fracture line, the relationship of the fragments to each other, and if the fracture is actually communicating with the external environment, defining it as closed and open fractures. All right. So is this points clear for you? Yes or no? Right. Okay. Now let's try to look at some classifications. Okay. How we actually define them. So if there is number of fracture fragments, now you see here, if there is only a single fragment, you call it as a, sorry, if the bone is broken down into two parts. Now you understand one thing here, okay? Uh, Let me actually show you, and let me try to define this one. Uh, just a second, maybe like this. Okay, just a minute. Okay, look at the image I have been sending you. You see here, it is actually classified as two things. A fracture can be classified as two things. It can be classified as a comminuted fracture or a simple fracture. Understand the only difference between a simple fracture and a communicated fracture is that, okay, fractures are there in both the situations, right? But the bone is actually divided down only into two parts, okay, the proximal part and the distal part. In case of a single fracture, yes, the fracture line is dividing the bone down into the proximal part and the distal part. But in communicated fracture, yes, it will be divided down into proximal part and uh, distal parts as well, but still the fracture will be present down at multiple locations, and then there will be a lot of fracture fragments. Okay, so a single bone that is broken down into different pieces, irregular different pieces, it is actually called as a comminuted fracture. Okay, so which means to say the bone has been separated down into many parts. But in a simple fracture, only it is divided down into two parts, which is called as the distal part and the proximal part. Simple. Did you understand this? Yes? Okay. Now, the second thing what we are actually going to do is that we are trying to understand the direction of the fracture line, right? The type of the fracture line. What actually happens, you see here, if the line of the fracture is coming along horizontally along the shaft or anywhere, not only shaft exactly, but along the, along horizontally along the bone, you actually call it as a transverse fracture. And it is 90 degrees, okay, it is perpendicular to the bone orientation. Okay, the bone is straight and the fracture line is horizontal, so there is a perpendicular orientation. But in case of linear fracture, where the fracture line is seen parallel to the bone surface, you see here, this is perpendicularly, which is called as transverse fracture, where this one is actually going down along the parallel along the line of the bone, we actually call it as a linear fracture. And you see here, there is another thing that is actually called here, all of them are simple fractures itself. Okay, do not confuse yourself, these are not comminuted fractures. Okay, until here these are all simple fractures itself. Only comminuted fracture is going to give you multiple fracture fragments. But now here a simple fracture do not have fracture fragments. But logically speaking, it has been divided down into two parts. What parts? The distal part and the proximal part. The medial part and the lanar part if it is in the, linear type. Okay, but if the fracture direction is present down from the one edge superiorly and going down into the other edge inferiorly, it is actually called as an oblique fracture. So the direction of the fracture is tangential to the surface of the bone, so it is called as the oblique fracture, which has got two types, where it is a non-displaced fracture, where the proximal part and the distal part did not get separated from each other, but still the fracture is present. So which means to say the anatomical orientation of the long bone is still intact, but it doesn't mean to say that there is no uh, effect on the joint. Of course there will be effect on the joint, but still the fracture points, the joint orientation and the anatomical contour externally actually looks intact. But if the fracture has happened like this obliquely, and now right now what actually happens is that the proximal part is actually moving down laterally, the distal part is actually moving medially. Okay, understand? So this was the road traffic accident I was talking about, the person who has had a complete femoral fracture, right? You see here, actually how was I able to tell that the proximal part is actually moving laterally and the distal part is actually moving medially? How could I say this? You have to know about the movements that is actually caused by this joint, right? So you see here, quadriceps femoris muscle is the one that is actually giving down a complete movements of the hip joint and also the thigh, right? The movements of the thigh are actually caused by the gluteus maximus and the quadriceps femoris, right? Which is helping down in flexion and extension of the hip joint. Yes, right? Okay, understand carefully, listen to my words clearly. Okay, hip joint is actually causing the flexion and extension by the quadriceps femoris muscles. Yes, okay, also at the knee as well, right? Gluteus maximus and gluteus medius also the one are the muscles that are involved down in the flexion, right? Flexion and extension, right? Yes, are you following me? Right? Now, what actually happens is that, let us say that the part of a bone has been fractured along this place. Now, there will be a pull of the quadriceps femoris muscle. Which one will flex the hip joint? So when it is flexing the hip joint, what actually happens? This one is actually moving laterally, right? Now, the communication that has still been present along with the muscles along the knee joint by the quadriceps femoris tendon, right, which will actually flex the knee as well. So flexion of the knee will actually cause the distal part go medially. Did you understand this? The continuation of the bone is lost, but the continuation of the muscle is not lost. So the muscle movement is going to happen and it is going to move the fracture parts, okay, the parts of the bone which is broken down into two parts in the direction according to the joints that are related. Did you understand this? So in a displaced fracture, what actually happens is this fracture fragment is actually moving laterally and this fracture fragment is actually moving medially. Yes, is this point clear? Because of the muscular movements, right? But here the direction is actually, we are talking about the displacement. Both of them are, you know, oblique fractures itself. One is still maintaining the anatomical orientation of the bone. One is not maintaining the anatomical orientation of the bone. And it is actually causing the displacements of the joints that are actually happening because of the movements of the muscle. All right. So that is what I want you to understand here in a displaced fracture and a non-displaced fracture. Yes. Is this point clear? Is Novella present here? Novella? All right. Okay. Some of her friends, please tell Novella that I'm looking for her. She doesn't seem to be presenting in the class. Well, okay. What about Dr. Bling? Where is this Dr. Bling? Okay, interesting. Okay, can a non-displaced fracture turn and displace? No, actually, you see here a displaced fracture, non-displaced fracture actually may not completely turn and in and displace. It actually depends on the still the connections or the extension of the fracture. You see here, most of the displaced fractures, non-displaced fractures are generally incomplete fractures. Okay, it might be happening only at one edge along the circumference. Let us say if there is a whole circumference, okay, only half diameter, uh, it is happening only to the half diameter or the radius or only to the one arc of the bone, right? See, they cannot be analyzed down in an AP view. Okay, the displacement or the non-displacement, okay, the fracture extension cannot be analyzed down in an AP view. It will be analyzed in both views, one on lateral view, one on an AP view, and then you can be actually understand if there is a displacement or not. Okay, but generally, if it is incomplete fracture, this it won't be causing any displacement. Or if the generally the fracture line is very intact, the displacement that has happened, the displacement is directly dependent upon the, the amount of the bone that has been destroyed. Okay, so that's the reason. Maybe yes, yes, if there is intern of the bone or the associated movements, yes, sometimes they can also be displaced. All right, yes, Shubham, did you understand this? Right. Okay, now, so that is the classification of the fractures. Then you have to understand that there is another direction of the fracture here, which is actually happening along all the circumference of the bone. Here you see here only one part of the bone here is involved, but you see here a spiral fracture is the one that is also happening as oblique, but still it is happening all along the circumference of the bone. All right, so it is tangential and it is spiral in nature. Okay, uh, there is technically not of a big difference between an oblique and a spiral fracture, but still a spiral fracture will involve the whole circumference of the bone. All right, then you can actually see here when only one part of the cortex has been disrupted, only one edge of the cortex have been disrupted, it is actually called as a green stick fracture. And where the fracture is breaking the bone down into several parts. Okay, it is breaking down it into 3 or more parts, it is actually called as a comminuted fracture. Okay, so there are something around like 6 types of fractures. Okay, understand, according to the direction of the line of the fracture. Okay, so first one is actually called as the transverse fracture, where the fracture line is horizontal. Linear fracture, where the fracture line is parallel to the bone surface. Oblique fracture, non-displaced, where the fracture line is tangential to the bone surface and the bones are not displaced. Where oblique displaced fracture, where the bones are displaced according to the direction of the muscle pull. Spiral fracture is a fracture that is happening along the circumference of the bone. Okay, and then green stick fracture is happening only a fracture along the edge of one of the cortex, not onto the other side of the cortex. Comminuted fracture, a fracture line that is actually transverse or spiral or oblique in nature, where it is dividing the bone into 3 or more parts. That's it. Is this all points clear for you now? Okay, this is a very important question. Remember, classification of fractures according to the direction of the fracture line. Okay, remember, this is a very important question. Okay, description of the fracture types according to the line of fracture line. Okay, direction of the fracture line, that is what is the a very radiological classification should be done. All right, now let's see the other parts. Okay, here you see here the direction of the fracture line, we are dividing down into transverse, obliques and spiral. Okay, diagonally it is happening, spirally it is happening, all diagonally along the circumference. All right, so now relationship of one fragment to each other. Okay, displacement can be there, angulations can be there, shortening can be there, and rotation can be there. Now, have you completed musculoskeletal system in diagnostics? Hairline fracture is the one you see here. Hairline fracture is there, but the fracture line is very thin as a hairline, very thin as a hair. Okay, that is actually called as a hairline fracture. It is just something like a very simple crack. Um, okay, I will show you. Okay, hairline fracture. Hairline fracture is generally a not a type of fracture. Okay, it is just only an appearance of a fracture. All right, very thin fracture that is present. It is not a type of fracture. Okay, but fracture classifications generally are done according to the what do you say, according to the direction of the fracture line. But this one can actually happen because of the point of impact. Okay, that is actually called as a hairline fracture. It is very, very difficult to diagnose a hairline fracture. Okay, see, the two images that I have sent you are the one that actually shows the hairline fracture. I think you can certainly appreciate it on the, on the distal fibula. I have shown that you can actually appreciate it where the arrow has been pointed. But I think on the fibula, which where the circle is present, I think you cannot actually appreciate that one. That is very difficult to find, but still the fracture is actually present there, because I can see that there is an inflammatory sign that is present down by the disruption of the cortex. Okay, and then along the distal edge of the fibula, here, tibia here, also where the arrow is pointed, it actually appears as a very, very thin line. Okay, second picture, yes, it is very difficult to interpret. So it is not actually a type of fracture. The fracture is there, but it is hard to find because it is as thin as a hair. So that is why we actually call it as a hairline fracture. All right, it is not a type of fracture. It is just only the appearance of a fracture. Okay, not according to classification of the direction of the fracture. It's not the type. Okay, it is just at the appearance. All right. Okay, now we are actually talking about a thing in diagnostic medicine. Have you completed musculoskeletal system in musculoskeletal system in diagnostics? Okay, okay. Now maybe I will open up my camera so that you can actually understand what exactly I'm talking about here. Just give me a second. Just give me a second. Okay, cancel. Um, let you show here. Okay, I think you guys cannot see me. All right. Okay, don't worry. Maybe I'll try to interpret with the images. You can actually understand. Okay, try to understand this concept a little carefully. Okay, because you should have learned this in, in the diagnostic medicine. But if you are unable to learn this one, uh, it should be difficult to understand what exactly is the angulations. Maybe when your teacher is teaching out the musculoskeletal system, maybe you ask her to explain about this much more clearly. You see here, Trendelenburg's test, it is actually called as the Trendelenburg's test. Okay, this is a test of a physical examination that is done in the diagnostics. Okay, it is actually done to analyze if there are any fractures of the hip. Okay, yes. Okay, what you actually try to do is that you actually ask the patient to stand on two legs. Okay, right, listen to me carefully. You ask the patient to ask the patient to stand on two legs. When the person is actually standing on two legs, what actually happens is that the both the anterior iliac spines, okay, both anterior superior iliac spines should be the same level. Okay, just a second. Okay, both of the anterior superior iliac spines should be present down at the same level in a straight line. Okay, can you see it here in this image? Okay, both anterior superior iliac spines should be present down in the same line. But at the same point of time, you actually ask the patient, okay, you ask the patient to lift the leg, flex the knee and lift the leg. rise the leg. At that point of time, what actually happens is one of the hip joint is either to go superiorly or either to go inferiorly. So there will be a tangential motion of the hip on the affected site. Okay, so that is actually called as a positive Trendelenburg sign, which will eventually cause the lessening of the length of the limb on the affected side. Okay, is this point clear? Okay, when you ask the patient to stand on two legs and ask the patient to raise his leg, and when you are actually trying to see is that there will be a positional change in the hip joint which is moving tangentially along the affected site, which will lessen the length of the limb. That is actually called as a positive Trendelenburg sign, which will determine the part of the which part of the hip joint has been affected. Okay, so that is how you actually do it, right? Is this point clear? Okay, maybe you can actually also learn in diagnostics class. Actually, this is a part of diagnostics class, but still a Trendelenburg's test is generally done. That's what I'm saying. You see here, it is actually caused by the movements of the adductors. Okay, it is actually caused by the movements of the normal abductors. Okay, you see here, it is actually caused by the weak hip abductors. Okay, abductors are the one that is actually pulling down the leg. Okay, the pulling down the hip joint to come closer to the body, right? So when you are actually trying to lift the leg, it will actually cause that such kind of movement will actually cause the adduction of that lift leg, and it is actually also going to pull down the hip on the one that is being supported. All right, did you understand? When you are actually trying to lift the leg, it is actually happening because of the adduction and also flexion. But the one that is present down on the ground is actually causing the abduction. So which one will actually cause that there is, okay, that there is a tangential displacement of the hip, which will actually lessen the length of the limb on the affected site. So which is actually called as a positive Trendelenburg sign, which is actually done in the analysis of hip bone fractures, hip joint fractures, femoral head fractures. Okay, no, generally you see here, you can not only actually do the ask the patient to stand, but even if you can actually perform this test even if the patient is lying supine. You will actually see if you are trying to actually flex the knee, what actually happens is that eventually there will be lessening of the length. Okay, generally it is not recommended no more. This kind of test is not recommended no more when there is a fracture of the hip joint. Okay, femoral head fractures or femoral shaft fractures, this test is generally not recommended now these days because the injury of the soft tissue structures is high and it might cause actually compartment syndrome. So generally you can actually, whenever there is a fracture, the first thing you are going to observe is that there will be going to be the lessening of the length on the affected side. Okay, that is what actually suggests you that there has been a clear displacement of the joint or the clear displacement of the bones or the fractures. Okay, yes, right. This can, I mean, this test is not only done, okay, the Trendelenburg's test is not only done to analyze the fractures, but Trendelenburg's test is also actually done to analyze the lumbar plexus problems as well. There is a gait problem that is also called as Trendelenburg's gait. Okay, Trendelenburg's gait. Okay, maybe if you have time, you should be actually learning them in your diagnostics class, because if you have completed them, then understanding it here is much more easier. So try to find out again what is a Trendelenburg's test, what is a Trendelenburg's sign, and a Trendelenburg's gait, And also in radiology, I have been telling you that there is a Trendelenburg's position, right? If you can remember, on the first day of the class, I told you that there is a Trendelenburg's position, right? So try to understand all the ones has got the same name. Every one is different, okay? It was actually given on the name of a Dr. Trendelenburg, okay? So Trendelenburg's sign, Trendelenburg's test, Trendelenburg's gate, and Trendelenburg's position. Okay, there are four things, so try to learn that one in diagnostics class later on. Ask your teacher to teach it. If not, that actually the logic behind this one is here. All right, then actually if I could have I don't know why my camera is not working, but if the camera is there, actually it would be much more easier for us to understand this one. Well, that one is actually going to cause the angulation. It is actually causing the shortening because it is happening because of the rotator muscles. The rotator muscles are the one that are responsible for adduction and abduction, right? So it is actually going to tell you the status of adductors and abductors. Okay, then the fractures can also be described if it is open or close to the atmosphere. Okay, if it is a completely open, it is actually called as a compound fracture. It is not closed and it is closed and there is no presence of the external environment, it is actually called as a closed fracture. Generally in closed fracture there will be no external hemorrhage you can actually be seeing. Okay, then in open fracture, yes, there will be external hemorrhages that can be seen. Okay, right, it is the same like things that you actually classified on the forensics as well. Okay, now I think we have already uh, I have make you understand all these things here, but only when it is coming down to the comminuted fracture, generally they have some special names. It is a segmental fracture, is comminuted fracture, which a portion of the shaft exists as an isolated fracture fragment. Okay, a segmental fracture. Okay, let me show you the picture so that actually you can understand. Can't see the slide. Oh, I'm sorry. Just wait. Now, can you see? Now, can you see? Right. Okay. You see here, one part of the bone is the bone has been broken down into several parts. Obviously the image I sent you, okay, the part of the bone has been completely uh, disrupted. Where can you guys still see now, or it can be seen now? Okay, you see here the image I sent you. You see this picture, what you can actually see is that there is the communicate. This is a comminuted fracture because the parts of the bones are separated down into three parts, right? Okay. Now, one part of the bone is actually separated from the other two parts. So that is actually called as a segment. So what is the segment here? This one is the segment, which means to say it is actually caused by two fractures here. Fracture along the proximal end and fracture along the distal end. But you compare it to the radius here, what actually present, it is just broken down into two parts, where it is broken down into the proximal part and the distal part. But it is compared down to the ulna, it is broken down into the proximal segment, distal segment, and the middle segment. So this one is actually called as a segmental fracture. Understand? And you can also see on the lateral image, there is also a fracture that is present down along the olecranon process as well. You see, there is a fracture along the olecranon process as well. So that's the reason you cannot actually analyze a fracture only on a single plane, not on a single view. Multiple views has to be taken. So this is a segmental fracture, comminuted fracture of the ulna, simple fracture of the radius. Did you understand this? Yes? So when you are trying to define, you are going to define it individually to the bones. So there is a comminuted fracture, a comminuted segmental fracture of the ulna, along with a oblique type non-displaced simple fracture of the radius. That is what I'm seeing in this image. Yes or no? And on the lateral side, I am also going to see that there is a fracture of the olecranon process as well. And olecranon process is present down in radius or ulna. Okay. See, did you understand the complete picture description what I did? Yes, Benedict, were you able to understand this classification? We have to define single, you see, you have to define single bone clearly. Okay, there is a segmental type of comminuted fracture of the ulna. There is a oblique type of simple fracture non-displaced in the radius. And on the lateral image, I can see that there is a olecranon process of the ulna fracture as well. So that is what the radiographic features you are looking at there, right? It is quite simple. It is not about defining, it is not about recognizing the fracture. The whole thing is all about recognizing the type of fracture, because recognition of the type of fracture is going to help you in designing your treatment strategies, right? Okay, so that's how you do it. But if there is a comminuted type, another type, which is actually called as the butterfly fragment fracture, okay, butterfly fragment fracture. Okay, I'll show you just a second. Okay, where look at the next image I'm sending you. Okay, see here where the fracture is actually present down, the fracture fragment has been displaced, the segment has been displaced, and it is actually looking like a butterfly. So that is how we actually call it as a butterfly fracture. Okay, all right, it is present down as a butterfly. Simple. Can everybody see the image? Yes. So it is a butterfly fragment. Segmental fragment is entirely different from a butterfly fragment. So that's it's only the the appearance how you are actually describing the fracture, but still fracture is fracture, right? Fracture is present already. Okay, so that's how it is. Uh, Let me take another 5 minutes and then we are done with the class. You see here, this is the segmental fracture. Can somebody tell me what are the bones that we are looking at? Okay, so you are looking at the leg, which is a tibia and a fibula, right? See, obviously, and you see here the S actually represents here the segment of the fibula that has been separated, and there has been, you see here, because the fibula has been divided down in completely three parts, where the one of the segment actually has been divided, which is actually the medial part, middle part, right? So this is the proximal segment, this is the distal segment, and this is the middle segment which has been displaced. And then you can actually see here that there has been a butterfly fracture that has been present down along the tibia as well. And this white hyperdensity that is actually showing up in between is the metallic rod processes that has been placed in the correction of this fracture. Okay, so this white thing that you actually see here is the metallic rod processes that has been present along the board, along the shaft of the tibia. All right, so this is the segmental fractures, and And you see here, this one is the butterfly fracture, where a butterfly fracture is a comminuted fracture as well, where the central fragment has got the triangular shape. So this is the butterfly fractures. So segmental fractures and butterfly fractures, right? So then you learned all about this diagonal transverse fractures, diagonals, obliques, and spirals, right? Let us see some images. Okay, this one is a transverse fracture. You can see that there is a transverse fracture radiolucent line along the distal edge of distal shaft of the ulna. Okay, that is how you are representing it, because it is present perpendicular to the long axis of the bone. Then you can see here, there is along the distal edge of the ulna, there is a diagonal hyperlucent fracture line actually present down to the normal axis of the bone. So this is an oblique fracture. Then you are actually looking at the spiral fracture here. You see here, this is a type of comminuted fracture where the fracture line has been extending down as two oblique fractures along one circumference, and then again on the diagonal fracture on the another circumference. Okay, so two circumferences are involved. On one circumference, it is actually present down as one diagonal fracture, and on the other opposite circumference it is present down as the other diagonal fracture. So this one actually twists down it as a spring. So that's the reason we call it as a spiral fracture. Okay, yes, twisting, when you actually try to twist a branch, it is actually called as a twisting or a torque injury. All right, is this point clear? Can somebody understand what is the difference? This is not comminuted fracture. Okay, spiral fractures are not comminuted fractures. Spiral fractures are simple fractures, but it is actually happening along the circumference. One circumference, okay, let us say there is the anterior circumference, okay, of the circle. And one half of the circle, actually you see that this one is the oblique fracture. On the posterior circumference of the circle, there is another oblique fracture. So two oblique fractures happening along the circumference, which is actually giving it a shape of a spring, is actually called as a spiral fracture. Is this understood? Yes. Okay. So that's, I think that's all the images, I guess. Let me see if we are getting down into some others. Yeah, we can also see that the fractures are descriptions. Okay, we can also saw the distal fracture, proximal fracture fragments as well, right? This is also completed. Angulation, shortening, and rotation also I told you, right? You see here there is a displacement. See, one fracture fragment, the proximal part here of the radius is actually displaced from the distal part of the ulna, distal part of the radius, where this one is actually displaced medially, this one is actually displaced laterally. So that is what the displacement is, right? Then the angulation, you see here, this one has actually caused the bone to completely bend, and there is angulation that is present. So that one is actually causing the angulated fracture. So this one is a simple fracture but causing with angulation. That is how you are doing it. Then last, you see here, shortening of the limbs generally will happen when there is complete displacement of the fracture. Okay, there is a complete displacement of the fracture, and one fracture fragment, one fracture part is actually getting down along the shaft of the other fracture part. So that one is actually causing the shortening of the length of the limb. So that is how is actually called as the shortening. Did you understand this part here? So this kind of shortening is actually called is called as shortening. But if it is actually increasing the length, okay, is actually called as distraction. Okay, it can also happen. Okay, see, this one is the distraction. Patella is the bone that you are looking at here. Okay, this is the left patella we are looking here, and here, this one, the patella has been fractured, where the one fracture fragment is moving above, proximally, superiorly, and the other fracture fragment is displaced inferiorly. So there is the increase in the length of the bone. So this one is actually called as distraction. Okay, this one is shortening, where the one fracture fragment is actually trying to invaginate into the other fracture fragment. Okay, so which will eventually lead down into the shortening, where this fracture, the fracture fragments are displaced opposite ways, one is superiorly and other inferiorly. So this is actually increasing in the length of the bone. So this is called as distraction. Okay, then closed fracture and open fracture. Okay, if it is communicating from the outside or inside, where the all the tendons and ligaments are actually shown up, and the one that is actually also causing avulsions, so that one is actually called as the closed fracture. Okay, which will actually lead down to the avulsion. Avulsion means to say the corresponding respective movements caused by the muscles and tendons and ligaments is actually called as an avulsion. According to the movements of the joint, this one will actually twist the bone. Okay, that is actually called as an avulsion fracture. Okay, it actually happens, some examples are there: dancer fractures, skier's fracture, and sprinter's fracture. Okay, I think maybe I will deal with this one later on. Okay, avulsion fractures we did not understand right now. uh, so we can stop here, I guess. Today's class we can actually stop here. So any doubts? Okay, remember the most important points: fractures of the fracture direction. Okay, that is one is an important question. Recognition of a fracture, acute fracture, radiological signs, that is an important question here. Okay, both of them can be asked as an essay question, or both of them can be asked as a 4 marks question. Case sheets there are there from fractures. Okay, right? So have any doubts for any session today?